welcome you to the Tuesday academic sessions by Yashoda Group of Organization. We bring some interesting topics every Tuesday from both Department of Acute Care Medicine, from Emergency and Critical Care, and we request or we bring our specialty clinicians who give us the expert opinion. So today we have Dr. Gopi Krishna, who is a senior interventional pulmonologist and has been an active part of the last 2 years of this pandemic, where he has a vast experience of both the sides with the pandemic and non-pandemic, the non-COVID infections also. And right now, over the last 6-7 months after the active second wave between April, May, June, we have seen a stiff decline from July, August, September, October, November. So definitely the COVID case numbers and the load and the strain on the system has been definitely been gone down. And we have seen a surge in other normal common infections, which we see every year, a surge in this cold months or this winter months. So for that reason, we brought this topic, thinking that in a pandemic, in an era where COVID apprehension or COVID related concerns as there, not just in the clinician's mind, also in the common person or a common public. So today we will actually take you through the review of literature. What are those other infections which we day in and out see during our non-COVID pandemic times in these winter surges over the last maybe 50 years or 60 years, whatever we have seen? Is that the same thing we see this year also during this COVID pandemic or post-COVID second wave? To review that literature, we have Dr. Hari Prasad, who is a consultant in critical care medicine, who will take us through for 20 minutes of that review of literature, followed by our expert, Dr. Gopi Krishna sir, will take us through those interactive discussion along with all of you. We have a team set of group of people who joined us can actually put their questions onto the group, and we will take those discussion for the further carry on. So I'll request Dr. Hari Prasad to start this presentation. Dr. Hari.
Yes. Good evening, everyone. Thank you, Venkat sir, for giving me this opportunity to present this small topic. As we are seeing, as there is a decline in the cases of the COVID cases since last few months, we are seeing other non-COVID cases, which we usually see in our previous practices, and how they mimic these COVID cases, why there is a dilemma between the diagnosis of COVID and the non-COVID cases, we will see in this discussion. First of all, as we know, the respiratory tract infection is caused by many of the bacteria like Streptococcus, Haemophilus influenzae, and Moraxella, atypical organisms like Mycoplasma and Chlamydia, Legionella species. They present with the typical bacterial pneumonia, whereas the less common causes like Pseudomonas and Enterobacterus family belonging to and methicillin-resistant Staphylococcus aureus, these are the rarest causes. But along with this, fungi also can present with the other respiratory tract infection like aspergillosis can also be present. But most commonly what we see in the upper respiratory tract infection and lower respiratory tract sometimes may complicated with the common respiratory viral infections, which we were seeing like respiratory syncytial virus, rhinoviruses, influenza viruses, human metapneumoviruses, parainfluenza viruses, along with other viruses, adenoviruses and enterovirus. We see previously we used to see, but due to this rise in the COVID pandemic and the first wave of COVID, due to strict lockdowns, so people using the social distancing along with the mask, the incidence of these organisms presenting to our presenting as infectious origin has declined. But due to ease of the lockdown, as the initiation of the travel and everything, the infection rates of these organisms and these the seasonal changes and the seasonal viral infections are also going up these days. For a clinician, we rely most of the time the clinical signs and symptoms to identify any infections, and in the respiratory tract, the most common symptoms which are common to these organisms are also along with the present pandemic like COVID-19. They both present with the same features like fever with chills, cough, there is shortness of breath or difficulty in breathing, sore throat, running nose, along with headache, muscle pain, body aches, and tiredness, generalized weakness. Sometimes GI symptoms like vomiting and diarrhea, they can also present. And most often we see in the COVID-19 that the milder form of symptoms, that is the change in the or loss of taste or smell, which is also present in other viral infections also. These infections may complicate with the pneumonia-like conditions, which may land up in ARDS requiring mechanical ventilation. And patients with in severe form of infection, they land up in septic shock along with the multi-organ failure. This clinical mimicry of the COVID-19 along with the other infections pushes us to for more rely on the investigation parts. And the investigation parts, we rely laboratory investigations like in a hemogram we see lymphopenia, leukopenia sometimes, or a rise in TLC counts. Along with that, other transaminitis in the deranged in the form of deranged LFTs and deranged RFT we see. But these are also commonly present in the COVID-19 along with the other infections also. So during the last 1.5 years, we mostly rely upon the CT findings, what we see in the day in and out as a screening to see the patient where there is any changes of that is related to the COVID or not. So this since last 1.5 years, we are mostly relying on these things. So these were the clinical mimicry what we see. Now we see the radiological similarities. These are the CT. This is the CT of showing the COVID pneumonia, where in the smaller in the early phase of the disease, from that is from the 0 to 5 days, we see a small areas of GGOs to normal along with the subpleural distribution of these GGOs. And in the intermediate state, we say a higher number of GGOs and denser areas of consolidation. And in the later phase, that is more after the 2 weeks or the 12 to after the 10 days, we see a mixed picture, that is the confluent lesions along with the consolidation and GGOs in bilateral distributions. Other rare findings we can see in the COVID patients are the crazy paving pattern and reverse holocene, but these are not typical of the COVID lung radiological findings. Now we see what are the diseases which can mimic or present like this condition in a radiological point of view. Also, this is the article published in the Internal Medicine Journal from the Japanese Society. First of all, we see that the first case, this is a 62-year-old male with a type 2 diabetes mellitus and hepatitis C positive who presented with fever and altermentation. And on evaluation, his CT showed multiple ground glass opacities, and the patient was suspected of having COVID-19, and he was isolated. Later, his condition deteriorated and required on a mechanical ventilation. And his repeated RT-PCR for the COVID-19 was came to be negative. But later, he underwent a bronchial viral ravage, and the fluid sample showed positive for the rhinovirus. On the right side, the typical CT findings subpleural GGOs which are present, which is shown in this picture. And as we have seen previously, also in the early phase of the COVID also we see subpleural GGOs which are in bilateral and subpleural in distribution. In the case 2, we see another case report where a single subpleural nodule was present in this case. And this is a 53-year-old female with a diabetes when presented with altered mental status and acute respiratory failures features. She had a history of contact with a coughing individual. And in this pandemic, we usually suspect to a patient with a contact with a coughing individual, unless proven it is otherwise, it is known to be a COVID. We will suspect in that case. And during the presentation and the history, we also they also found that they has a productive cough along with the wheezing for the several days. And the CT is showing the single subpleural GGO. And she was later repeatedly tested for the COVID, and the test came to be negative. And after that, the tracheal sample, when she was intubated, and the tracheal sample was sent, and the PCR assay for the metapneumovirus came to be positive in this case. In this third case, it is a 76-year-old woman who has a history of bronchial asthma, presented with a dyspnea and wheezing. And on the CT, we see multiple areas of GGOs, with a crazy paving of a pattern. And the PCR panel PCR panel showed rhinovirus, and the repeated COVID PCR tests were negative in this case. This is a 45-year-old male with a bronchial asthma who presented with cough, fever, cough, diarrhea, and generalized fatigue. And CT showed multiple areas of the subpleural GGOs and distributions. And repeated RT-PCR were negative for this patient for COVID-19, whereas the sputum sample sputum sample for PCR was positive for the influenza A virus. Apart from this radiological mimicry, other these are the viral illnesses what we have seen presenting as a COVID-like CT findings. These are the other case reports from the India. In the Kerala, they have presented this case report where a 69-year-old male presented with a fever, dry cough, and progressive SOB of 1 week duration. His when he was evaluated, there was his chest X-ray is showing this kind of picture along with elevated inflammatory markers and was suspected of COVID-19. Later, he was isolated, and later repeated tests for the COVID-19 were negative, and his CT showed initial picture of this on this side, on right side it was shown, and which showed features of interstitial lung disease pattern, possibly infective virology, etiology, and Corax 5 was given. The atypical pneumonia panel which were sent, which came to be positive for the mycoplasma pneumonia. And this is a case of 23-year-old male, 23-year-old male with a history of diarrhea for 1 week duration. He was having a high-grade fever, tachypneic tachycardia with room air saturation of 85%. With oxygen, his saturation improved to 95%. And which showed the peripheral, the hemogram showed lymphopenia with elevated D dimers, and other inflammatory markers are also elevated. His HRCT is suggestive of bilateral GGOs with right middle and lower lobe arterial thrombus. So high suspicion of COVID was taken in this case, and he was repeatedly came to his COVID test for repeated RT-PCR came to be negative. Then he was later underwent a BAL, and BAL samples came to be positive for the pneumocystic cerevisiae and cerevisiae. After that, they were evaluated and came to be HIV positive with a CD4 count of less than 24. With all this, we see that these are the atypical presentations of the normal infections. The presentation now for previously pre-COVID era infections, which we see, which mimicking the COVID in the lung CT findings, along with the clinical features, along with the laboratory investigations. Also, with this, the dilemma comes whether how to diagnose these infections in a condition where the the COVID vaccination drive has increased the vaccination, the decreasing number of cases, and presence of these kind of symptoms makes the clinician more dilemmatic for an approach how to diagnose these cases. Here comes the role of the molecular diagnosis, what we will discuss in the next. These are the features, some of the features which are apart from that, which gives a clues to the diagnosis of other than the COVID, like atypical GGO distribution, that is like a sparing of the subpleural areas, or unilateral distribution, tree in bud pattern, moderate to severe pleural effusions, segmental or lobar consolidation with ground glass opacities, diffuse nodules, which are most commonly seen in adenovirus and herpes virus kind of thing, mediastinal lymphadenopathy, pneumothorax, pneumomediastinum, and lung cavitations. These are rare findings, and if these findings are present, the clinicians should suspicious for the other cause of the infection, other causes or the non-infectious causes for the CT changes of the patient's condition. Here comes as we are discussing, the dilemma for the diagnosis is present. So here comes the role of molecular diagnosis. Why the molecular diagnosis is important? Because in the conventional diagnosis, when we take whether a gram strain or a culture for the we take these takes times, and sometimes culture comes after 2 to 3 days also, or even delayed also, and other serological markers also takes time, and the time the initiation of treatment is delayed in them, and the accuracy with which they become like on the interpretation of the result from the gram strain and other serological comes as accuracy is also questionable. So the role of molecular diagnosis comes here, as most of the time in the COVID pandemic, they have taken the larger seat role, as the PCR based technologies are identifying the COVID early. So we are also taking the PCR-based channels, PCR-based assays for these tests, and molecular tests such as RT-PCR or LAMP, like that is the loop associated isothermal nucleic acid amplification test. And the recent ones are nanotechnology based diagnosis methods, which use the nanoparticles like gold and silver particles, and other like nanomaterials like albumin microspheres. And these use the particular sequence or a particular epitope or a particular antigen of the virus or other bacteria, they particularly mark that area, and they can give the results in a very a smaller time frame. And now the molecular diagnosis after this COVID pandemic, they are going into a point of care diagnosis, which based on less than 20 minutes or 30 minutes for diagnosis, like a lab on chip or a, nano electromechanical systems also. Now this is the this is the one journal I can found where biomedical engineering, they have given that how the recent nanotechnology, recent RT-PCR or the nucleic acid amplification tests and other conventional tests differ or the different. The first comes to the nucleic acid amplification test, where we see the viral panel what we send in a respiratory film array panel, where they use the PCR method, so that the detection time is very less. It is maximum is for the 480 minutes, but we can get it within less than an hour. So when a patient comes to an OP clinic or an emergency department, we have if we can send a sample after processing, and the result can come within 1 hour. So the initiation of treatment can be appropriate in them. They have a high specificity and sensitivity also, the PCR based tests, what we use for the common viruses like MERS virus or the mumps, influenza, rubella viruses. These can also be used for the bacteria like tuberculosis, also pneumococcal, and other fungal conditions like aspergillosis and candidiasis also. These are the nanotechnology based. They have not yet FDA approved. They are not in clinical practice. They are available in certain high quality laboratories, but not available presently. They use gold particles, and we have seen. And the recent COVID-19, they have detection like the COVID rapid antigen test. They use the silver particles in them as a nanotechnology with a sensitivity and specificity higher, more than 95%, and almost reaching to the 100%. The duration here, detection time is 10 to 15 minutes, and maximum is for the influenza, which comes around 60 minutes. These are the nanotechnology which will take a part in future, and for the diagnosis as early as less than 20 minutes or 30 minutes in the direction. These are the same other particles like nanomaterials, micromaterials, those are used, and they have also same, the detection time is almost around 15 to 20 minutes, apart from the few in which few viral antigens. There is after this PCR bench, there occurs a dilemma, because after this PCR assay, they detect the smallest fragment of the nucleic acid present. So what happens if there is a colonization, or if there is any co-infection, or if there is any super infection? So that is a dilemma. So this study or this article, which is present in the Infectious Disease 2021, they have found that the PCR panel detects the more of a bacteria. The PCR-based film array detects the bacterial co-infection, which is more common in moderate to critical COVID-19 patients. And these are where their viral and atypical bacteria are very less. So this also leads to the increased amount of the antibiotic use in them also, due to the detection of these bacteria, whether they are causing any harmful to the patient with the co-infection or not, that we cannot predict at this moment of time. This is the after from that we see that how these PCR based panels helps in us the diagnosing the other condition, as the COVID cases, new cases are falling after the vaccination, and this vaccination and the cluster also are coming down in the COVID cases. This is the article produced from the published in the CDC, where the morbidity mortality week for the where they have seen the changes in the influenza and other respiratory virus activity during the COVID-19 pandemic in the United States. This is the showing. The blue line is for the 2020-21 for where, whereas the other lines in 2016-17, this line is for the 2018-19. The dotted line is for 2016 and 17, and this continuous line is 2017-19. They have seen that influenza virus rate has come down throughout this 2020 and 21 season, whereas the respiratory syncytial virus cases is going up from the May 2021. And whereas the human metaneurovirus is also almost very less. Along with that, the respiratory adenoviruses and rhinoviruses and the enterovirus cases are also increasing trend. This is the report from the Singapore. They have also similar kind of presentation. Till 2000, till the initiation of pandemic, COVID-19 pandemic, the flu season was high. After the first case, there is a significant drop down in the COVID cases, influenza cases, along with the other respiratory viral infections. But after the reopening phase 2, they have seen that there is a quite a surge in the respiratory syncytial virus, enterovirus, and rhinovirus cases in them. After that, So these how these infections interact with the SARS-CoV-2, whether they increase the condition of the disease severity of the patient or decrease, or is there any effect as there in interaction is there or not. But initially, this was the top paper published in the International Journal of Epidemiology. They have shown that between the initial phase of the COVID-19 from the 20th January 2020 to 25th April 2020, they have tested, and they have shown that when there is an influenza positive cases were high, they have seen that the SARS-CoV-19 test was positive for only 58%. That is a decrease in the test negativity or false negatively they were high, and the infection causes more severe disease in them, like ventilator use, death in the intensive care unit. So they have shown that in the initial phase. But as we have seen the film array during the co-infection studies, the impact we cannot assess at presently. The data needs to be further analyzed. Coming to we are into the coming into the influenza season, seasonal flu season. So we will discuss regarding this, and the global influenza surveillance response system, given the guidelines in the recently, they have shown that the influenza activity from September 2020 to the January 2000 mostly present in the countries like the tropics and the subtropical countries. And the influenza virus tested positive is less than 0.2% of the total samples those were tested. But what happened is during this time, the non-pharmacological interventions like stricter lockdowns, social distancing, most of the people wearing masks for the COVID prevention measures were going on. So they have given that these measures may have decreased the incidence of the influenza in these conditions. But despite of that, they have also shown that there is a new virus emerging from the influenza H3N2 in the Cambodia and Bangladesh, which later circulated to the all over the world. The Sentinel survey system of the 45 countries, they have reported that the influenza circulation is ongoing despite of the COVID-19 lockdowns and COVID-19 preventive measures. In this view, taking into all these consideration, the US CDC has recently recommended that routine vaccine should be the routine influenza vaccine should be co-administered along with the COVID-19 vaccines. There was a debate about the whether the influenza vaccine, how the COVID vaccine and influenza vaccine interact. This was the one trial which is showing that in the phase 3 randomized trial, which showed the co-administration result in the changes in the influenza vaccine no change in the influenza vaccine related immune response, but there is a slight reduction in the COVID-19 vaccine related immune response. And taking into all this consideration, the how the co-administration, how the two vaccines interact, how much is the side effect from the each of the vaccines we have to look into. And the studies, the clear data is still not available. It will come into the future. And recently, the Australian authorities also recommended the co-administration of COVID-19 vaccine along with the influenza vaccine with a 7 days of a minimum gap. Previously, which was used to be 14 days for two live attenuated vaccines, but they have reduced it to the 7 days now. From this, we can take the minimum points where we can see with the COVID vaccination drive and falling number of new cases, we need to be more vigilant about the COVID mimic infections, which were present in the community previously also, but due to stricter COVID related preventive measures, the incidence of which came down. The influenza, other respiratory are masked during the COVID event, and when they present, when the lockdowns and the reopenings occurs, they can re-emerge as the epidemics again. In the surge can occur or the clusters can occur again. And when both of them can present, they can present as a co-epidemics, which will be more further difficult to control them also. The rapid diagnostic tests are required for the early diagnosis and early initiation of appropriate treatment and other public health related issues like isolations and cluster isolations to be done if there is an influenza or other viral infections are spreading. And the molecular diagnostic will take part in the future where they will help us in the potential identification of potential antigenic sites on the viruses, which can lead to the development of successful vaccines and rapid detection of viral variants also. And at this present, as the seasonal flu is coming, season of flu is coming again, vaccination of influenza is utmost important in this case. With this, we will see. Thank you.
Dr. Venkat, please unmute your mic.
Thank you, Hari, for that overview of clinical mimics, radiological mimics, then the surging of the conventional regular infections, both atypical and viral, and some evidences or some case reports and series. With this, we will take interactive session with our senior clinician, Dr. Gopi Krishna sir. Sir, actually, the routine viruses and bacteria, which has been a regular part of our life in these seasons like winter seasons and other seasons in the cities with so much of pollution. Somehow in the year 2020, where there was a strict lockdown and a COVID appropriate behavior because of apprehension was very strictly followed, we have seen a dip in cases, any other form of respiratory infection. We have seen a lot of surge in COVID infections in that period. I'm not sure whether it is due to the lockdown or precautions, or because of apprehension, people didn't turn up in the hospital. So now in the last 5-6 months, when we saw the COVID cases has definitely gone down after the vaccination drive and drop in the wave surge. Now we are seeing a lot of trickling down of tropical cases like dengue, and along with dengue, we are seeing a lot of SARI cases, that is severe acute respiratory illnesses. So now in the background of COVID era, last 2 years, we have been going through this COVID pandemic. How do you see these cases which are coming with severe acute respiratory illness to your emergency and your ICUs and your OPDs?
Good evening. So, Hari sir, it was really good presentation. Before I answer your question, I would like to talk about something like crazy paving pattern, which you have shown. Crazy paving pattern, we have seen lots of cases in COVID, and I can say that the crazy paving pattern is a bad prognostic sign. That I would like to stress, because most of my cases got intubated and some we lost. And second, sir, regarding your question about the SARI cases and what are the, what different infections we are seeing. So it's a big problem what we are facing nowadays. The reason is, so whenever the patient walks into the ER, there is a big confusion whether this is a COVID or non-COVID.
Yes.
So how should we go about? So whenever we see a case with respiratory illness, then what we do is primarily we do a CT screening and we do a rapid antigen assay. So based on the rapid antigen assay, if it is positive, it's clear that we have to send the patient to isolation. And when we see the CT scan, if the CT scan is like what Hari Prasad sir said, like there are GGOs or there are consolidations which are bilateral and typical, can be a COVID. In spite of your rapid antigen test, still we isolate them. That is first in regards to logistics. Second, in regards to the approach to the patient, the second thing what we try to do is after isolation, then we try to sample. We send the blood investigations as well as the sputum investigations if the patient is able to produce, or if he is an intubated patient, we try to do the bronch and send the lavages. Along with that, what we are trying to go about is with we call it as a rapid fire film array test, which we do, which gives around 24 to 38 number of all different organisms, including the viruses as well as the bacteria. So that helps us in identifying and minimalizing the thing like this patient is a COVID patient or a non-COVID patient. So along with the RT-PCR and the film array, then we conclude, yes, he's a patient who is non-COVID, so we shift him out of isolation and then subsequently manage these patients. The big issue is like, just with one sample of RT-PCR, we cannot say it as a COVID negative. So if the clinical suspicion, with the team of doctors, with the intensivists, as well as the clinician, like the pulmonologist or the internal medicine guys. So if they strongly feel this can be COVID, just wait for 4 days and repeat an RT-PCR is the protocol what we follow in Yashoda Hospitals. So if the second sample is negative, then he'll go out of the isolation. This is how we are approaching SARI cases in Yashoda.
So very interesting, sir. How are you actually seeing in the last maybe 3-4 months? You said many centers may not have a facility to have these all panels available, like a molecular diagnostic. But the information which we carry from any centers may give an idea to overall prevalences or incidences of the non-COVID SARI cases. So what was your experience? Have you seen any surge in non-COVID viral infections, atypicals, tropicals in recent times where you taken into them as a SARI, then investigated them? What is your experience in the last 4-5 months?
Yeah, what you said is absolutely right, sir. In the last 4-5 months, we have been seeing there is a dip in COVID, but there is a rise in atypical infections, which we broadly classify them as. So what personally my experience was, the influenza B was topping the list. But of course, this is after my film array results.
Yeah.
And followed by leptospirosis, with a lot of leptospira IgM are turning positive, and few cases of scrub we have seen. I'm not sure about the internal medicine statistics. And along with that, we saw a few cases of respiratory syncytial virus, and we saw some other what you call these
atypical bacteria,
adenoviruses and rhinoviruses. So there was little severity associated with adenovirus, what particularly I could say, as well as respiratory syncytial virus. But the influenza B, though it presents as a scary picture, but ultimately the patients tend to improve. And leptospira, as you all guys know, like, it takes time, and with the simple antibiotics, they do get better. And it is the tough part is not only with the smaller centers who can't reach up to the film arrays, but what about the cases in the OPDs? It's a big challenge even for the the clinicians who are sitting in the OPD rather than only in the ER or in the ICU. So we don't do film arrays in the OPD basis. So that's a big challenge what we are seeing. So we are giving a routine prescription of some antibiotic and supportive medication, sending them home. They're not getting better, then again we have to admit them and then send the investigations. So my personal thing is most of these viruses, whatever you name it, whether it's an RSV or an adeno or H1N1, most of the times very few viruses have medications.
Yes,
so
exactly.
As a broad spectrum, when you don't have an access, you can always start oseltamivir, and if you can isolate RSV, then probably a ribavirin can be given, or else most of these viruses are only symptomatic management and a supportive management with the team. I think they do well. Only thing is, the atypical bacterial, the mycoplasmas and leptospiras have to be identified along with scrub. So those things, the treatment is different and the way they present is different. And sometimes they progress a little faster when compared to these viral infections.
So it's a very interesting component. As you said, most of the centers may not have all these respiratory panels. And as you rightly pointed, in centers where we have all of them in OPD patient who is not that severely in severe respiratory illness, so we may not able to prescribe them because of the cost implication. And as you said, options available for the treatment. So you recommended in a case where I have a suspicion of a atypical pneumonia, whether it can be a viral or a bacterial, we empirically cover influenza and send for a probably influenza screening if you feel so, and cover a atypical bacterial. And keeping an eye, rightly pointed out, in the recent time, we have seen a kind of lung involvement with tropical fevers, including leptospira, and in a scrub typhus and few of the dengue patients who came with a very late ARDS pictures. So this has been an overlap in many of the times where we have seen. Sir, you also pointed out many cases where we admitted with a SARI and we had a suspicion of COVID, and they have been into isolation, and we have sent an RT-PCR. Initial RAT is negative, followed by RT-PCR is negative. Then how do you actually deal with them? You discontinue the COVID treatment, or what will be your protocol or approach in those situations? Initially, you suspected a COVID, but later on your RAT and RT-PCR is negative, they are in isolation ward.
Sir, I would like to answer this question in a two-pronged way. See, one is on the lines how we talk to the attendants and the patient, because that's the big thing which matters the most. They are a little scary and they are aggressive sometimes. They are apprehensive. The best word would be the apprehensive thing that, we dump the patient into COVID ward. So he doesn't have COVID, whether he might get COVID. So when he is in an isolation ward with a single room, it's fine. Or else if he's in ICU, then what about our patients? What is happening to them? So then we have to talk to them, tell them exactly, like, sometimes the RT-PCR can be only 60% sensitive. So in that what we do is we start the therapy, we continue the therapy, telling them that, the conventional therapies, what we give for COVID are absolutely safe and they don't harm the patient in any ways, even if they don't have COVID. This is how we approach in our hospital, talking to them. The second thing, as a clinician, yes, I would like to go with the standardized therapy for COVID, in spite of RT-PCR being negative in the first RT-PCR. I don't consider RAT as a first investigation. RT-PCR would be your first investigation. If it is negative, still continue. Wait for 4 days and repeat an RT-PCR, and then take a call whether the patient is a COVID or not. So meanwhile, should we give the therapy for COVID? Yes. But should we give, therapy like, aggressive doses of steroids or the monoclonal antibodies like tocilizumabs or infliximabs or methylene blues? I'm not sure. I don't do that. So unless you have a clinical evidence or a serological evidence stating that he's a strongly COVID positive, better avoid those things, because the patient can well be an influenza case or an RSV, or he can be oriental like a scrub or anything else. So those drugs can literally take into a stormy picture, and we might lose the patient. So avoid the immunosuppressants of the monoclonal antibodies, and the conventional therapy of remdesivir, steroid can always be given as a standard protocol in any other viral infections or atypical infections, what we do. So our standard protocol of therapy is, when we don't have a diagnosis, fluvir to be added, doxycycline to be added. These two things, along with some broad spectrum antibiotic, and wait for the results, is the protocol how we are approaching the case with RT-PCR negative with SARI and CT appearances are bad.
So you mean to say that the clinical acumen and the clinical diagnosis, along with the radiological evidence of typical CORAD 5 with a high suspicion of COVID ARDS or COVID pneumonia, should be continued irrespective of the RT-PCR negative in the initial part, and continue at least the conventional, which has proven standard therapies like steroids or remdesivir or anticoagulants like that, till you get further evidences, you mean to say. And in most of these cases, you try to add other two, you said influenza and probably a doxycycline, which causes atypical and tropicals together. So I think that's the way approach. And in the 4-5 days therapy, most of the remdesivir duration also gets over for a moderate to severe cases. And at that time, if you get a second RT-PCR negative, then you probably look for other alternative things and try to move out. I understand it's not just a scientific and clinical and radiological equipment, but the family apprehension, which plays a lead role there, where they repeatedly come and question your decision of keeping these patients in isolation in spite of 2 repeated negative tests. Sir, where do we actually, you place this the rapid diagnostic, molecular diagnostics? Where do you send these rapid molecular diagnostic in these patients? You said initially a rat RT-PCR in all suspected SARI cases with radiological evidence, clinical evidence. That is one. Then we are talking about if it is negative, but you have a high clinical suspicion, you continue the therapy and repeat one more. And there were other cases of SARI where you may not have a typical COVID like picture, but there is still a suspicion with a CORAD 3 or 4. With some of the times I have seen you sending an IgM, which coming positive in them, and you still keep a very suspicious eye on them. So where do you actually keep these rapid diagnostics, that's a molecular diagnostic, placing them in these patients?
Sir, talking per se about the guidelines issued by Infectious Disease Society of America, there is no role of rapid tests, especially the rapid antigen test can be used as a tool, for epidemiological purposes or ER screening tool, not to be used as diagnostic modality in a high-end center or tertiary care center. Point number one. Second point regarding the immunoglobulins about IgM and IgG. So initial days, during the first wave when we didn't have any guidelines, we tried using them because it was a full-blown pandemic, and where initial RT-PCRs were negative, but the IgM turning positive and IgG turning positive, that state where we didn't have vaccination too. So now we are in a state, the pre-COVID vaccination era and the post-COVID vaccination era. So I used IgM as well as IgG, kept the patients in COVID and treated them in an aggressive form and sent most of them home. But in the second wave, where there were, little bit vaccinations going on and most of the people had vaccinations, I couldn't rely on IgG because there can be a false positive rise because secondary to the vaccination, or probably a subtle infection which he had earlier and the IgG can be positive. But regarding IgM, the Infectious Disease Society of America, which has released a guideline of late, states not to use IgM or IgG as a diagnostic modality to identify our COVID. So the role of IgG or IgM would be only epidemiological or to check whether to give a plasma or not. They have ruled out giving plasma also now. The role of the plasma and IgM, IgG are obsolete now, sir.
Yeah.
So we had used initially because we had used lots of things during the first wave and as well as the second wave.
So a lot of learning curves there. Yeah. I also wanted to know about, or probably put across an interaction regarding the other molecular diagnostic tools like that, what you mentioned, the rapid diagnostic tools which are available for a PCR panel or molecular diagnostic for other viruses. For example, how you place influenza evaluation or other viral and atypical pneumonia panel. Where do you place? You send these all at the beginning, you send a COVID, it comes negative, then you evaluate for them. How do you place them?
First thing, if the rapid antigen test is negative in the ER, then we bring the patient into the the isolation, and then if there is a strong suspicion that this can be a non-COVID. See, COVID, there are diffuse GGOs, bilateral, subpleural, very classic. Then I would like to wait. I don't want to send 25, 28,000, 30,000 birth film arrays just like that, because the whole cost of therapy would be gone in it of COVID. Second, probably, I would like to wait for the RT-PCR. If the RT-PCR is negative and the patient is still requiring oxygen or he's still febrile or the symptoms are still persisting, probably as a second step, I would like to send the respiratory tract film array or this molecular, analysis of the cluster of viruses as well as the bacteria. And not as a prima facie tool, like, as soon as the patient reaches, we don't do that here. So we do it as an optional tool. When we couldn't confirm that it was not, whether it's not COVID, then probably we'll use this as a tool to identify.
I think some of these cases which actually come out of this COVID isolation saying this looks like a non-COVID. We have repeated twice, and now we have an influenza positive, respiratory syncytial virus positive, or metapneumovirus virus positive. Some of them became very sick also. We have seen some of them landing into severe ARDS, severe hypoxemic, requiring a repeated proning. And in the last, I think, a month or so, we at least had to prone almost a half a dozen of cases continuously for 10 days to bring them back. But fortunately, these patients don't behave the same way what we have seen with COVID.
Yeah,
They
exactly.
do recover well. They don't go into any fibrotic phase. Critical illness polyneuromyopathy was not been common. They like what we seen in pre-COVID era. The same thing has been also reflected in them. So there another interesting part. What we wanted to know is in the last year in 2020, we have not even clinicians. Most of us has skipped the dose of influenza vaccination. Many of our kids who are going to school earlier used to have an annual vaccination, at least influenza. So somewhere this all is breached, and many of high risk group also could not actually get access to this influenza vaccines, and even the conventional pneumococcal vaccines if somebody were pending for a proper pneumococcal vaccines. So do you think this also contributed, or do you think the now just open up things without much COVID appropriate behavior, there is a surge? What could be the reason of there is a surge?
I would like to say all the reasons, sir. Basically, the delay in the vaccination of influenza, what I'm talking about, and the myths people have, we already took a COVID vaccine, both are viral vaccines, why should we take an influenza shot again? And like Hari Prasad sir had already said, what is the interaction between the COVID vaccination and the influenza vaccination? So these are all the doubts, commonly people are expressing in my OPDs. So earlier it used to be a routine protocol that, the patients used to take the influenza shot by June, July, and they're done with it. But now, because of the COVID and the COVID vaccination, they're more concentrating on COVID vaccinations. There's a lot of delay and lot of, what you call gap in the vaccination of influenza. One reason could be that there is a surge of influenza. Second, this is a common season where we see lots of influenza cases rising up. So that is another second point. Third, not that every patient who is vaccinated with influenza is not going to get influenza or a H1N1. That's another point. Just like COVID, that's also around 75 to 80% only sensitive in protecting the people. Third would be the COVID appropriate behavior is slowly going down in the public, where we can see that most of the people are not there is absolutely no social distancing, which we are able to see, as well as lots of people are not using masks properly. Could be the third one. And we all know that influenza spreads really faster. We can say that faster than the COVID. So thereby there can be a lot of rise in cases, and probably we'll see lots of cases more. Now the schools are going to go open up.
Yes.
The colleges are coming up. So, and the movie theaters, everything is open now. So I think we'll see a huge surge of influenza rather than the COVID in the next couple of months is my thought.
Hari, you are talking about the interaction between two vaccines. So you said there were some reports where the influenza vaccination itself has some effect on severity of COVID illness, and there were some preventive aspects of that. And now there are some guidelines from different authorities, including some Australian authority who says that you may come the closer. Some of the CDC guidelines says you can have a co-administration of both vaccine on the same day. So what is your take on these two vaccines putting together, as many had doubts on that? Can we actually take the two vaccines on the same day? We need a delay of that, and one vaccine protecting the other, or interaction between them?
Sir, the CDC guidelines says they have to start they recently CDC guidelines says that they can have the both sorts together, both COVID and influenza. Whereas the Australian, they give a maximum duration of 7 days between the two doses. But what I have seen from the literature, what I got from this thing, the only one study, that is a phase 3 clinical trial, which showed that the immune response to the COVID is decreased due to the after taking the sort of the influenza vaccine. But from a one study from the Italy, where they have not published it. It was in the pilot study they were taking up. They have as an interim analysis report, they have told that when almost around they have taken 8,000 of people into consideration, where they have taken both the sorts, both influenza and COVID vaccine, both the sorts. So at the first sort of the COVID, they have taken the influenza vaccine, and all of them came back at the destined interval time period for the COVID vaccine too. There is no as such as any infection or any side effects or anything. But this was not completely published yet, so that I could not put it into this thing. This was an interim analysis report they have updated in between only.
So both the vaccines can be taken simultaneously,
Yes, sir.
or a gap of 7 days, but both can be taken without any interaction. Both
Yes,
have
sir.
been considered to be safer.
Yes, sir.
So
And
I want to make.
yeah, sir.
Yeah. Sir, I don't want to go with any of those studies. They are too early. See, the vaccines they had were mRNA vaccines. The vaccines we have in India are entirely different. The vaccines in China are different. The vaccines in Russia are different. I'm talking about COVID, right? So the interaction of those vaccines with influenza, no one knows. Absolutely knows. So CDC is talking about, the mRNA vaccines, what they have, and the interaction with the influenza they have given that you can go ahead. So my personal take would be a gap of 7 days would be ideal.
Okay.
A gap of 7 days would not cause any detrimental things. It's just a vaccination.
Yes.
And vaccination is a protection mode. So rather than, you can avoid all this clutter of things like, there are interactions and all. Obviously patient will also have pain. He's already scared of COVID vaccine, getting a fever. So you give this vaccine also, he'll think this is a vaccine which has got him into a fever or anything. So to avoid all that confusion for the clinicians as well as the common public, I would suggest give a gap of 7 days, at least 7 days. 7 to 10 days is fine. Go for COVID followed by influenza shot. That would be a better model rather than going with the studies. The studies are still, they are very, very, very premature or primitive right now, because we don't know how these vaccines are going to interact, because we have more than a dozen of vaccines which are available across the world now, all different models and different types of vaccines of COVID.
And this protection which has been debated and assured with different influenza MMR has also been debated. So not very conventional evidence at this point of time to actually say in for or against them. So the other point is a co-infection. Sometimes we do come across a patient who had a co-infection. See, in influenza time from 2009 to 2015, we have seen a lot of bacterial, particularly strep pneumoniae and staph as a co-infection in them, and it has been worldwide. But the similar kind of pattern has been not very commonly seen with what in the recent pandemic of 2 years. But what was the co-infections with viruses? Or any information from viral co-infections during this period?
Sir, my experience, I have seen only single viral infections most of the times. Very, very rarely we see, a combination of influenza with adeno or adeno with some atypical bacterial infections. This is how I'm trying to see, but not COVID as well as influenza together, or COVID as well as H1N1 together. I have not seen till now. So like Hari Prasad sir said, they can be detrimental, but still they are all case reports which are coming up. We still don't have the exact how dangerous they are. So anyways, we have therapy for COVID, but we don't have any particular therapy for influenza other than the H1N1. So a broad cocktail, if you really suspect and you turn out to be positive, then probably an addition of oseltamivir for a few days might help them out.
Right. I think in the right ways to put it across, sir, as you said, we do not have therapies to majority of these viruses, except this probably influenza and maybe respiratory syncytial virus. Those are also experimental. Probably the influenza is one. If you get across in the first 72 hours of the viral initiation, probably it will be effective. So in this situation, do you think H1N1 alone with a atypical pneumonia panel maybe one way of quickly seeing, because these have a therapeutic implication, whereas the others you just need to continue the supportive care. So is that the one way to go ahead if somebody don't have the full respiratory panel, do an influenza test, send a typical pneumonia panel if that is available with them, and because these both has some therapeutic interventions, the rest probably may not have any interventions to do.
Exactly, sir. It's only a supportive therapy. So I strongly suggest, to start off with oseltamivir. The max side effects, what you can see with oseltamivir is only with the GI disturbances. Very rarely we see, QT prolongations and all. Nothing to be worried about these oseltamivir per se. So I feel to start off with Fluware along with the conventional antibiotic would be better when you don't have the tools to diagnose the H1N1 or any of these viruses.
There was a question from the Kondal Reddy saying ki, many of the things which you said can mimic. Clinically, things can mimic, probably radiologically also things can mimic, particularly viruses and atypical pneumonias and PCP pneumonias. So in this situation, PCS being expensive deals and not available everywhere. So any other diagnostic tools which we can use? I think there's a partially answered, but to re-emphasize, can you just repeat, sir, Gopi Krishna, sir?
Would be really difficult because there are no other tests where we can really identify these viruses other than the PCR based assays. Commercially, they are available, instant kits and all, but they are not that sensitive. Second thing, one particular point I would like to say, sir, not only, we have been talking about infections only. There are non-infectious diseases which mimic like SARI or, which mimic like COVID.
True.
So that's another big, entirely different headache where, we have to, dig into the things and, identify the other etiologies
Yes.
other than infectious things. So I feel per se, if we have the tools, right tools at the right time, definitely can save the patient. We don't have really, right tools, at least start off the therapy and search for the places where we can, send the patient or refer the patient so that, they can get better faster is my thought, personal thought.
So what about the common chronic respiratory illnesses coming with this infections other than COVID right now? See, my experience with the last 2 years, along with all our pulmonology department colleagues, is we have not seen many asthma exacerbation during the COVID. Not many COPD patients coming onto ventilators. I don't know whether it was a protective phenomenon or they were more worried and more careful. So what is the magic the pulmonologist did to all of them who were protected?
It's not the magic of pulmonologists. It's the magic of COVID. First is the fear that, you go to a hospital which gives a COVID care, they are literally scared to come over here. So most of the times they are ending up, taking primitive therapies in the nearby hospitals or some, nearby clinics. And second thing, because of the scare of COVID and all, most of the people stopped, going out and interacting. So the spread of viral infections are anyways down. Third, the mask is helping them a lot. At least when they are in public, they are trying to use the mask, I'll not say absolutely, but trying to use. Probably these are the things which are helping them not reaching the intensive care of tertiary care centers and all, probably.
Are these cases now piling up because there is an open up, the lockdown has been dropped? So we see now in the last couple of months more COPD exacerbations, more as asthma exacerbation, ILD exacerbations, which we are seeing.
In the last 3 to 4 weeks, I have been seeing, a lot of ILDs coming up with exacerbations, especially, with the viral infections and all. And yeah, that particular set of COPD patients who tend to, get admitted in the end of September, that phase is gone. So I'm not seeing much of COPDs, but definitely a lot of asthmatics and allergic patients who have been stable all these years, are turning up in the last few weeks, coming to the OPD initially. If they get better, it's fine, or else they are getting admitted also most of the times. So probably because of this complete relaxation, what we got, especially in India, the third wave, which is not seen or not probably might not come, is the sense of security which people are going out and started mixing up with the people. Probably that's the reason they are having a little infectious things with especially the allergic patients are coming up. COPD, absolutely, they are very, very less what we have seen. A lot of allergies and asthmatic patients are coming to the OPDs and to the ICUs. Other than that, the non-COVID things are rising up, like ILDs or newer ILDs which are silent, COVID-related ILDs. Now there is a mix of COVID fibrosis with ILD. So a lot of mix and match are happening. So it's really difficult when we try to handle these ILD patients who are having an attack.
Post-COVID cases coming up with some new exacerbations or new infections?
Yeah, that is rising, sir, now. especially the people who had a stormy, what you call course during the hospital, where they have been, in the ICU, or they have been ventilated, or they have been requiring high oxygenation. They are the people who are coming up with secondary infections and getting admitted and going bad again. So they survived the first attack of COVID, but most of them are succumbing to the secondary infections which they are getting in the lung, especially, typical full-blown ARDS in just a couple of hours, or a max of 24 hours. We are seeing that patients are going on to ventilations and all. So this, I'm seeing the trend. So we have a doubt, like, can they be, embolisms? One of the thought. Of course, they are already on blood thinner still. It doesn't mean that, patient who is on blood thinner or on any injectable anticoagulants does need not develop an embolism. Can be that thing, or like Hari Prasad sir said, like secondary infections with the other viruses are also dragging them to the hospitals.
Co-infections with COVID. Now we have been talking about it, bacterial co-infections.
Yeah, most of the times it is bacterial rather than two viruses together.
So most of them are hospital acquired, probably when they were invasively ventilated in
most of the times, rather than directly landing up onto the, in the OPD or ER with the bacterial infections is very rare, sir.
So take home message for all clinicians who are watching you in this COVID or a post-COVID second wave, in a time where we are seeing a lot of atypical, tropical, viral, non-COVID infections. Take home message, sir.
First thing, isolate every patient who is a SRE suspect, so that, you minimize the spread. Second thing would be, start the appropriate therapies until you have confirmatory couple of tests from the RT-PCR. Third would be, a cocktail regimen, you can say, like, a broad spectrum antibiotic and doxycycline, and along with the Fluver will definitely help. Regarding the starting of remdesivir or steroids, it's a personal thing. What I say, like, if the CT is scary, then better you start remdesivir and low-dose steroids too with anticoagulants. Definitely there is no harm in doing it. As you all know, remdesivir is also an influenza-based drug, rather than, of late we discovered that it works on COVID too, and it helps only in 10% of COVID cases. So there is nothing wrong in starting it. The fourth point would be, vaccinate all the patients who are, who have comorbidities, especially the diabetes or hypertension or cardiac disease, whatever it is, or patients who are already, recovered from COVID. Do get them vaccinated with influenza, if possible, pneumococcal too, so that, you can prevent at least the new influenza-related attacks for these patients, or reduce the severity of influenza-related infections. And last but not least would be, regarding I just lost it, sir. Sorry.
So do you think that we should be vaccinating this post-COVID patients who had actually a lot of parenchymal lung damage, and they are on the recovery phase? They should also get the influenza and pneumococcal vaccination at this point of time?
We can do it, sir. First point, they should not be on steroids. The maintenance dose, post-discharge, there should not be any steroids. Second, if they are not having any active inflammatory signs like, fevers or any other, body pains or joint pains and all, then better we get them vaccinated. There is no contraindication, or there is nothing, we are going to lose, or, they are going to get worsened with this thing. So most of the times, all my patients who are post-COVID, we are getting them vaccinated.
And other point which you actually mentioned in the middle of your conversation is non-infective mimics of COVID.
Yeah, the last one.
Kept in mind, and probably if you don't find an infective etiology, watch out for all the non-COVID or non-infective mimics, which looks like a GGOs, which looks like a patchy peripheral consolidations. And
those things should be worked up properly.
Yeah. Thank you, sir. It was a pleasant experience and learning curve for many of us, including me. It was an interactive and interesting part of it. Thank you, Hari, for bringing this review of literature. I hope and thank all the participants who actually enjoyed this session. And with this, I conclude the session. Thank you, sir.
Thank you very much, sir.